Hello, everyone. Good afternoon. I'd like to apologize for the delay of this program. So sorry, I'm having some technical issues and challenges. I would like to specially welcome each and every one of you to today's CPD event organized by Sevier. My name is Samuel Kwabneje. I'm a pharmacist and I work with Sevier as a key account manager for Ghana. So today's virtual CPD is on the optimization of treatment for your patients with hemorrhoidal disease who are already being treated with topical formulations and analgesics, but are still suffering from pain and bleeding. And this is going to be a clinical case study. So, to facilitate this discussion is a fellow, a general surgeon, and a hepatopancreatobiliary consultant at the 37 Military Hospital in Accra. So, help me welcome Dr. Nabil Mohammed Niama to
Yeah,
facilitate this CPD.
yeah.
Thank you very much, and a very good late afternoon to all our listeners. Yes, today we'll be discussing, a case presentation on hemorrhoidal diseases. I mean, I'm sure many of you are quite familiar with this condition. It is quite a troublesome condition, quite a very common condition, and understanding it and knowing how to treat it effectively is quite important. So today we'll be discussing a case presentation on hemorrhoidal disease and how to optimally manage this condition effectively. You're all welcome. It's the wrong one. You need to change it.
Almighty.
All right. Okay, listeners, sorry we have a little small technical hiccups, but now I think everything is fine, so we can start. Um, yes. Like I said earlier on, sorry for the small hiccup. We have a small technical hiccup, but now it has been resolved, so we can continue. Today we're going to be talking about optimization of hemorrhoidal patients who have already been treating themselves with, different types of, topical analgesics and, suppositories, as you already know, but still having recurrent pain and bleeding. We start with our case presentation. We have a 37-year-old female patient who presented with bleeding perirectum for 3 months, had anal swelling for the past 2 months with pruritus within the last 2 weeks. History of presentation of this patient. Patient first noticed blood streaks on toilet paper after defecating 3 months ago. The blood was bright red and it was quite small in quantity. There was no pain associated with the bleeding initially. She did not do anything about it until bleeding became quite frequent, meaning, having almost daily, what do you call it, bleeding per rectum after defecation. She reported to a herbal hospital where she was given some herbal medication, which actually resolved the bleeding temporarily for her. However, symptoms keep recurring and also noticed an anal mass protruding from the anus during defecation 2 months after the initial bleeding episode. The swelling was initially painless and reduces spontaneously when the patient rises from the toilet seat. However, the swelling gradually became irreducible and started becoming painful. And most of the time, she has to use her fingers to reduce it because of the pain associated with the swelling being stuck at the inner area. She tried several local medication, but symptoms did not resolve. Therefore, she finally presented to our clinic for management. On direct questioning, there was pain associated with the swelling, which reduces manually. There was no dizziness, there was no palpitation or easy fatigability. She denies having any diarrhea, but has intermittent constipation. That means she moves her bowel every 2 to 4 days. She passes her stools with straining. There was no melanoma stools, no abdominal pain, or no weight loss associated with her symptoms. In her past medical and surgical history, there's no known systemic disease, had two cesarean done. The last one was done 8 months ago. In the drug history, she has used different herbal preparation in the past to manage her, her bleeding and pain, problem. Currently on anosol and paracetamol, which was given to her 4 days before her presentation to our clinic. In the family history, parents are alive. Father has hypertension and was diagnosed with hemorrhoids about 20 years ago. She has 4 siblings, two of whom also had similar intermittent bleeding per rectum symptoms. On social history, she's married with 2 children, lives in Accra with two of her siblings, does not smoke but drink alcohol occasionally, and works as a secretary in a company. On physical examination, the BP was normal, 188 over 82 millimeters of mercury. Her pulse was 80 beats per minute, regular and good volume. Her respiratory was 16 cycles per minute. SpO2 in room air was 97%. Body temperature was 36.8 degrees Celsius. She weighs 82 kilograms. Her height is 168 with a body mass index of 29.1 kilometers per meter squared, kilogram per meter squared, meaning that she is overweight. The physical assessment, patient was awake, alert, and oriented, not in respiratory distress, not pale, not jaundice. The cardiopulmonary assessment shows he has normal S1, S2 heart sounds with regular, which were regular with no murmurs or no extremity edema. Respiratory sounds were normal on all lung zones, no rouse, bronchi, or wheeze were heard. The abdomen was not distended, it was soft, non-tender, no palpable mark. Bowel sounds are normal pitch and frequency, and there were no palpable organomegaly. At the anorectal region, the anal hygiene was good. There were no external hemorrhoids noticed. However, there was an anal tag present at the 6 o'clock position. Anal mucosa was protruding at the anal orifice upon asking the patient to strain, that is on Basava maneuver. Digital rectal exams showed palpable anal mucosa swelling. There were no palpable mass in the rectal bowel. So in summary, I present a 37-year-old female patient presenting with 3 months history of intermittent bleeding per rectum, followed by anal mass protrusion and pruritus. She had a history of intermittent constipation and positive family history of hemorrhoids. Examination showed palpable anal mucosa swellings, and the examining finger was stained with normal stools. So with this history and physical examination, we came up with a provisional diagnosis of, second to third degree hemorrhoids with differential diagnosis of diverticular disease, angiodysplasia of the rectum or the colon, anal fissure, most unlikely because, the examination was not all that very tender, and then a rectal neoplasm or polyp was also part of the differential diagnosis. So we went ahead and did a protosigmoidoscopy for this patient on an office basis. And then after the protosigmoidoscopy, we realized that there was no any other relation apart from the internal hemorrhoids that we saw on our physical examination. The sigmoid colon mucosa was normal. So that brings us to the end of the case presentation. So now the question is, how do you manage this patient? Before we move on to the management we do to diagnose them in the overview on management, then we'll come specifically to the treatment. Smooth muscles, and the name of the smooth, as we normally call them, the trace muscles and elastic connective tissue. So that is what a hemorrhoid is made up of. In the epidemiology, it affects almost about 4% of the world total population. So now if we project the total world population to be around uh, 8 billion. The number of people who are suffering from these diseases is
Hello, everyone. Would like to apologize for the technical hitches. I would kindly entreat each and every one of you to have some patience with us and kindly hold on. The facilitator will be back shortly. Thank you.
I think we can go on. It's
So, as the we can continue. All right. Sorry, we are back. We are back online again. We had a little bit of technical problem, so we are back. We've done with our case presentation. So now the question we have to ourselves is how do we manage this patient? So before we go on to the specific management of our patient ANN, who is a 37-year-old female, would want to have a general overview of what hemorrhoidal diseases are, how do we, what do you call it, diagnose them, and how do we manage them before generally we come specifically to the case that we presented, how we're going to manage that patient. So in the general overview of hemorrhoidal diseases, and we said that by definition, hemorrhoid diseases are abnormal enlargement of the anal conditions which are highly vascularized discrete submucosal masses consisting of blood vessels, smooth muscles that generally are termed the trimegaly muscles, and elastic connective tissues. For epidemiology, it affects almost about 4% of the world population. So if we project the world population to be around 8 billion now, at least we could, imagine the magnitude of this problem and, the number of people who are actually affected by this problem. It affects approximately 1 million people every year in Italy. That means that almost about 2% of the total population of Italy gets hemorrhoids every year. It peaks between the ages of 40 to 45, but however, it can occur at any age. Like I said, we are seeing as young as teenagers coming to the hospital with hemorrhoids. And 4 out of every 10 patients with hemorrhoidal disease will become symptomatic. In the pathogenesis, there are two main pathophysiological mechanisms that accounts for the development of hemorrhoids. The first one is actually the chronic straining mechanism. And by this, it causes vascular engorgement and dilatation, stretching, and disruption of the supportive connective tissues within the hemorrhoidal cushions, therefore leading to the swelling of these hemorrhoidal cushions. The second pathophysiological mechanism actually relates to the resting inner pressure canal that actually increases in these patients. And this increase in resting inner canal pressure causes decrease in venous return, venous engorgement, disruption of supporting connective system, and therefore enlargement of the anal cushions. Types. There are three main types of the hemorrhoids. We have the external hemorrhoid, the internal, and then the mixed type. For the external hemorrhoids, we say they are hemorrhoids that actually develop from the anal mucosa below the dentate line. That is, any hemorrhoidal cushion or any hemorrhoidal swelling or mucosal swelling that arises from below the dentate line is considered to be an external hemorrhoid. They are supplied with somatic name because they develop from an ectoderm. And I said this is a very important factor that we need to bear in mind because it explains the most important symptom that the patient comes to the hospital with. The second one is internal hemorrhoids, and these are hemorrhoids that are located above the dentate line. They develop from the ectoderm, and hence they are supplied with what? With visceral nerves. Anatomically, they generally arise at the 3, the 7, and 11 o'clock positions, and when they arise from these locations, they are considered to be primary hemorrhoids. And then sometimes we see them at the 1, 5, and then the 9 o'clock positions, and in these positions, they are considered to be what? Secondary hemorrhoids. However, or let's say in addition, the internal hemorrhoids can also be classified according to the Golgi's classification, giving rise to how they protrude, the degree of of prolapse of the inner cushions out of the anal canal. So they are classified into grade 1 to grade 3. We talk about grade 1 internal hemorrhoids. We are talking about hemorrhoidal cushions that are located within the anal canal. Grade 2 means that the cushions are protruding from the anal canal on straining, but however, reduces spontaneously. Grade 3 is what anal cushion protruding from the anal canal that do not reduce spontaneously, but however, can be reduced manually. And then grade 4 are the ones that cannot be reduced at all. The third type is the mixed type. That's a combination of both the internal and the external hemorrhoids. Now let's come to predisposing factors. What are the factors that predispose people for developing hemorrhoids? We talk about genetic factors, and as you could see in our presentation, our patient's father had symptoms of hemorrhoid. Therefore, you could see that it runs within the family. So there's a very strong genetic predisposing factor in this condition. The second predisposing factor is obesity. People who are generally quite heavier than what they are supposed to be. So obesity also produces predisposing people developing hemorrhoids. And if you could see from our patient also, she was also quite heavy, meaning that she was overweight, and that could also be a predisposing factor. Prolonged straining, conditions that predispose people for, predispose people to straining, for example, constipation, diarrhea, BPH in men, or people or men who have what prostate cancers actually predisposes them to straining when they are urinating, and for that matter, hemorrhoidal development. In females, we have pregnancy, which is one of the commonest predisposing factor of females to developing hemorrhoids, and not just pregnancy. Females who go ahead also to have normal vaginal delivery are also at a risk of developing hemorrhoids. And we have dietary factors, that is, diets that contains low fibers, spicy food, alcohol are all included in the predisposing factors. The last one is, men and women who involve themselves in anal intercourse. Right? That can also be a very important risk factor for developing hemorrhoids. So here we have a pictorial, what you call display of the internal, both the internal and internal hemorrhoids. We have to the left external hemorrhoids, that's hemorrhoids that are developing from below the dentate line. And then in the middle, we have the internal hemorrhoids with their different grades. That's the grade 1 to grade 4. Grade 1, we said hemorrhoidal cushions that are within the anal canal. Grade 2, we said those ones that protrude from the anal canal but reduces spontaneously. Grade 3 are the ones that produce from the anal canal but has to be reduced manually. And grade 4 are the ones that do not reduce at all. And then the one to the right is both the mixed type, that's both the external and the internal hemorrhoid type. How do these people present, or how do these patients present? The most commonest presenting complaint is bleeding. In general, this bleeding is, comes with bright red blood, and it is painless bleeding. Sometimes they will come with local swelling around the anal canal. Sometimes they will come with anal discharge or soiling of their underwears. There is also sometimes pruritus, a feeling of incomplete evacuation of the rectal fullness. All these things are complaints. Sometimes they could have pain. That is, people who have hemorrhoids, when they complain with pain, and that means that it is a hemorrhoid that is mostly complicated, and the most common with external hemorrhoids, or a complicated internal hemorrhoids could also lead to pain. And when the internal hemorrhoids are complicated, mostly they come with thrombosis, ischemia, or strangulation. How do we diagnose these conditions? We diagnose these conditions by history and physical examination. These two factors are really very, very important in the diagnosis of hemorrhoids. Then after that, we do some intervention to confirm what probably we are suspecting. And generally, it's an office-based, interventions. We could do the anoscope, or we could do the proctoscope, and with this, we could see the hemorrhoidal cushions easily. Sometimes, in order to differentiate other conditions from what actually is causing the hemorrhoids, we could do the full colonoscopy, or sometimes we could do the barium enema for differential diagnosis. What are the differential diagnoses of this condition we have? It could be just a normal rectal prolapse. It could be a malignancy, inflammatory bowel disease, diverticular disease, rectal polyps, anal fissures, abscesses, and perianal endometrioma are all conditions that sometimes can mimic hemorrhoidal diseases. How do we manage hemorrhoidal diseases? Treatment is actually classified into 3 categories. We have dietary and lifestyle modification, we have non-surgical approach, and then we have the surgical approach. Now, the important factor here is that mostly a combination of these treatment modalities is used based on the presenting complaint, the size and the grade of the disease, and other comorbidities present in the patient. So none of these actually treatment modalities, per themselves is sufficient to actually treat a hemorrhoidal disease completely. We need to combine, them in most instances based on the factors that I just mentioned about. The first one we need to consider is dietary and then lifestyle modification. What are the things that we can do as far as our diet and the lifestyle is concerned in order to minimize, or to manage our hemorrhoidal condition? The main goal of this treatment modality is actually to minimize straining. Once we're able to get ourselves from straining, then the risk of we developing hemorrhoids, or even if we have it, the risk of it becoming bigger and more troublesome is reduced. The first one is high fiber diet. Food that contains high fiber is what is necessary to prevent us from developing hemorrhoids or to prevent the progression of the disease. That is fruits, vegetables, unprocessed wheat, oats, bran. These are all foods that contains high fiber diet that really help. Consumption of adequate water and liquid. We all know that the colon, one of the main functions of the colon, including the rectum, is absorption of water from the chyle that is coming from the small bowel. Therefore, the longer the what do you call it, the stool stays in your rectum or your large intestine, the more water will be absorbed. For that matter, the more you get constipated. Therefore, if you consume adequate amount of water or enormous amount of water, that prevents our colon from absorbing a lot of water from our stools, therefore making our stools less hard. The third one is fiber supplements. Sometimes we could have some supplements in our food that makes it, have a higher fiber content that helps us to be able to prevent us from what? From getting constipated. An example is the psyllium seed that we can now sometimes add to our food and helps to prevent us from getting constipated. And there's two softness, for example, lactulose and so on are all, medication that we can use or additives that we can use to make our food soft, our stools softer. The second one is to avoid prolonged standing or sitting. People whose jobs are normally involve standing or sitting for long periods are predisposed to developing hemorrhoids. So if you do have such a job, then intermittently it's very important that you take other conditions or other precautive measures into consideration to prevent yourself from developing hemorrhoids. And then also it's important that we stop the habit of ignoring the urge to defecate. This is very important because, like I said, the longer the stool stays in your rectum, the more harder it gets. So when you get the urge or you feel the urge of what? Of moving your bowel and you keep postponing it, after some hours before you can probably maybe find yourself, easing yourself, you realize that the stool has become very hard and therefore predisposed for straining. And if that happens, then you may end up developing hemorrhoids. Physical exercise is very important because it helps in our bowel movement and everything, speeds up the bowel, peristaltic movement, and therefore makes our stools less hard to prevent straining. Sometimes we will do sit baths for symptomatic relief of pain or to reduce edema. Mostly we see that in 3rd to 4th degree hemorrhoids, where sit baths are necessary to reduce the edema and therefore help in the management. The second treatment modality is the non-surgical approach. And here we are talking about the use of medications, specifically the use of flavonoids, for which Daflon is an example of these flavonoids. What are these flavonoids? These flavonoids, they are used as venoactive drugs or phlebotonics. Their main action is actually to increase the venous tone, therefore reduces capillary permeability, vascular endothelial activation, and therefore inflammation. So you realize that all these mechanisms actually geared towards reducing the edema, shrinking the vascular engorgement within these hemorrhoidal packets, and therefore making it shrink. And that's the action mechanism of these flavonoids. They are most widely studied and used. The most widely studied and used phlebotonic is the macronized purified flavonoid fraction, MPFF, of which what we know in the market to be known as Daflon. Now, the use of the MPFF, that is the macronized purified, flavonoid fraction that we're talking about. How do we arrive at these being quite effective, for the treatment of hemorrhoids? There are 3 important meta-analyses. And when we talk about meta-analysis, we are talking about the degree of what evidence-based. And meta-analysis is almost the 4th layer of what evidence-based to show that, in fact, the evidence supporting the use of these products for what they call it, for the treatment of hemorrhoids is really quite strong. The first one was the meta-analysis done by Alonso Colo in 2006. And in this study, about 14 studies investigating these flavonoids treatment, as MPFF, the diosmins, and then the glucosides for the treatment of hemorrhoids, were included in this study. And it was reported from this meta-analysis that these flavonoids reduces the risk of not improving globally by 58%, with apparent reductions in the risk of bleeding, pain, itching, and then recurrence. The second was the Cochrane meta-analysis by Pereira, which was done in 2012. And it was on hemorrhoidal treatment with flavonoids. And the study reveals statistically significant benefits in bleeding and overall symptom improvement in acute hemorrhoidal disease and in bleeding after hemorrhoidectomy. So it means that this study this meta-analysis even showed that these flavonoids are not necessarily used just only for patients who are not undergoing surgery, but even those who have surgery also benefit from the use of these flavonoids. The third and the most recent meta-analysis was done in 2020 by Sheikh et al. On the use of MPFF in hemorrhoidal diseases. And they reported that MPFF treatment can significantly improve the most important signs and symptoms of hemorrhoidal disease that include bleeding, pain, pruritus, tenesmus, anal discharge, and leakage. The surgical approach. What surgeries do we normally do for these hemorrhoidal diseases? The first thing is that every patient with hemorrhoids is not, surgery is not, let me put it this way, surgery is not suitable for every patient with hemorrhoids. So surgery is generally reserved for some specific, group of patients. I'll come and then we'll talk about the indication for surgery in hemorrhoidal diseases. So the surgical approach is divided into two groups. We have the office-based and then the minimal procedures and hemorrhoidectomies. The office-based procedures are generally used as first line of treatment for patients unresponsive to non-surgical treatment. Therefore, it means that before we even begin to think about surgery, first and foremost, we need to think of treating these patients medically. If they do not respond, then we begin to think of surgery. And when we begin to think of surgery, the first approach will be the office-based or the minimal procedures that we need to think of. And generally, these ones are reserved for the low-grade hemorrhoids, mostly the grade 1 and the grade 2, and the uncomplicated cases. These office-based procedures include band ligation, injections, sclerotherapy, infrared photocoagulation, cryotherapy, and so on and so forth. Let me open up a small bracket over here that these office-based, procedures or minimal procedures are quite effective. However, their recurrence rates are really quite high. The other surgical approach is the hemorrhoidectomy that we do. That's removal of the hemorrhoidal packets themselves, and it involves excision of the prolapsed hemorrhoidal cushions. Which patients do we recommend these surgeries for? One, those with advanced disease, that is the grade 4 and sometimes grade 3 patients. Complicated cases, that's cases that comes with thrombosis, incarceration, and strangulation. And also patients who fail to improve after multiple applications of non-operative treatments are also suitable candidates for hemorrhoidectomies. So that is the general overview of the treatment for hemorrhoids, how they present, the pathophysiology underlying the condition, the risk factors underlying the conditions, and then how you're going to manage these patients based on all the different treatment modalities that I mentioned about. And it's important to know that, like I said, these treatment modalities are not applied singly. Generally, we combine them to get the most effective, outcome for our patients. So having finished with that, now we turn our attention to the treatment of our patient ANN. How are we going to treat this patient? Number one, we are going to give her copious oral hydration. She's not a patient that actually needs, admission. We can treat her on an outpatient basis. So one, we are going to advise her to drink a lot of water. Like I said, in the dietary and the life modification arm of the treatment modality, I made mention of use of oral hydration, and also high fiber diet. That means that we are going to advise her to start taking a lot of fruits and vegetables and food that contains high fiber so that her stools become soft enough to prevent the progression of this disease. The second thing is we are going to start her on stool softness. Only we told you that she'll be having intermittent constipation, so she will need, a short course of stool softener. You can use lactulose to make your stool soft so that the disease doesn't progress and then stop the bleeding also as well. The third thing that we have to, give to her is to start her on oral flavonoids, that is MPFF. And the product in the market is what we call Daflon. So we are going to ask her to start taking Daflon, you know, and then after that, we'll come back and then we'll review her after a couple of weeks of Daflon treatment. When we're using the Daflon treatment, for the initial acute phase, generally we can go at a dose of 1 gram, 3 times a day for the first 3 days, and after that we can then, spread it to 1 gram twice a day for a period of about 2 weeks, and then you can review your patient to see how the progress of the patient. The fourth is, on review, bleeding. When patient comes after 2 weeks of review, the bleeding has stopped. She moves her bowel more frequently. She doesn't have constipations anymore. That she moves her bowel once or twice a day, and her stools are still bulky but soft enough to prevent her from bleeding. She was finally reviewed after another 2 weeks of the conservative management, and this time her anal muscles protrusion has stopped. That means that the hemorrhoids have shrunk in size. And then she noticed that about 10, for the last 10 days, she has not bled. She has not seen any mass protrusion from the anus. So we can say that our treatment plan had worked perfectly for this patient. For that matter, progressing to surgical intervention wasn't necessary. Thank you very much. And we pause here for our Q&A section. Thank you.
Thank you so much, Dr. Nyama, for such an insightful and very concise presentation. I think it's very clear. The clinical case study is very practical and very relatable. So thank you so much for sharing your experience with us. So before we go for the questions and answers, we'll do a short presentation on Daflon, which is a flavonoid, as Dr. Nyama mentioned, which is being marketed by Servier. So I'll do that short presentation, and after that, we'll take the questions and answers. If you have any question, kindly type it in the chat box so that we read it and then Dr. Nyama will answer appropriately. And a kind reminder that after the presentation, there will be a post test on the CES website. Kindly go through the post test and then complete it. That will earn your CPD points. Kindly do so. Thank you. So yeah, good afternoon again or good evening. I'm Samuel Kabineje. I'm a pharmacist and I work with Servier as the key account manager. So we're just going to discuss the place of Daflon in the management of your patients with hemorrhoids. Dr. Nyama, who is the expert, has said a lot, so I'll just make this very brief as possible. Just go to the main point. And it's been found out that 1 out of 10 of the population suffers from hemorrhoidal disease. Dr. Nyama gave us a very good statistics to that effect. Okay, but the interesting part is that these patients wait on the average of 9 months before they even see their doctor. So you can imagine within this period, they resort to herbals, they resort to friends' advice, they resort to self-medication. Is very alarming. So by the time they come to the clinic, as you already see, most of these patients come in their worst state or condition. But how do we manage these patients medically? From guidelines, so this is a French coloproctology guideline, which is just to buttress or reiterate what Dr. Nyama shared with us. Okay, so there are the various options of treatment. So we are looking at the local treatment. So we have the suppository creams. Okay, but then it's interesting to note that when it comes to the classification or the recommendation, we have grade A and grade B. Grade A classification always has the highest form of recommendation, and those are highly recommended. Okay, so looking at the local treatment, the recommendation is grade B. Looking at your modifiers of transit, your laxatives, also the recommendation is grade B. Okay, when it comes to NSAIDs and steroids and central analgesic agents, they are saying that we should ask for experts' opinion. But the main recommendation, number one recommendation with grade A, are venoactive drugs, okay, of which Daflon is an example. Okay, so these are other guidelines which agree with the French coloproctology guidelines. So the American Gastroenterological Association makes mention of MPFF, which Dr. Niyama mentioned, as recognized treatment for pharmacological treatment of patients with hemorrhoidal disease in reducing all the signs and symptoms of hemorrhoidal disease. Okay, so what is Daflon? So Daflon is a micronized, purified flavonoid fraction. So Daflon has a unique composition of 5 active flavonoids, which contribute to the efficacy of the MPFF. Okay, so we have the diosmin, which is the main active ingredient. We have the hesperidin and other flavonoids which are expressed. Okay, so I know one of the main questions that will come up with what's the difference between Daflon and Flavodia. So this slide is very important. So Daflon has a unique composition of the 5 active flavonoids, including diosmin. Okay, but Flavodia is only diosmin. It doesn't have the 4 other flavonoids. And these 4 other flavonoids contribute to the synergistic activity of the MPFF, with what is very important to us being the hesperidin. So hesperidin is a vein-specific analgesic agent which reduces the pain at the level of the venous wall. So that brings the advantage or the value you have with Daflon. On top of the diosmin being a venotonic agent, the hesperidin is reducing the pain and inflammation at the level of the venous wall, which Flavodia doesn't have. So this is one of the main differences between the two. Secondly, in terms of absorption, Daflon has a better absorption. So generally, the diosmins are not easily absorbed in the GIT because of the large particle sizes. But with Daflon, we've micronized the diosmin. So micronization simply means we reduce the particle size. So reduction of particle size from our basic pharmacology would mean a rapid onset of action, easier absorption rate. So comparing Daflon, which is a micronized diosmin, to Flavodia, which is a non-micronized diosmin, Daflon will have a 58% more absorption rate compared to Flavodia, which will have about 32% absorption rate. This is very important because in this condition, you would want your patient to get a rapid relief from their pain and other symptoms. You want your patients to even sit down comfortably after an hour of taking Daflon. That is very important. That's a value Daflon brings to your patient. And this was seen in one of our studies, okay, which showed that Daflon had a 58% more absorption compared to the non-micronized diosmin. And this is as a result of the micronization. Okay. What about the efficacy? Looking at the efficacy of Daflon, from the second day, you are getting about 8 out of 10 of your patients getting a complete relief from their signs and symptoms. And by the 7th day, about all your patients will get a complete relief from their signs and symptoms. You're looking at the bleeding, the pruritus, the pain, at a dose of 1 gram TDS for 7 days in the acute phase. Okay, so this was a randomized, double-blind, placebo-controlled study involving about 100 patients with acute hemorrhoidal disease. They received either the MPFF, which is Daflon, or the placebo for 7 days. And the results were very excellent in favor of Daflon in reducing the signs and symptoms of your patients. Okay, and unfortunately, as you already know, with this condition, patients may relapse because of a number of factors. As Dr. Niyama mentioned, there are risk factors associated with hemorrhoidal disease. So unfortunately, the patient relapses. What is the place of Daflon? So Daflon, given at a dose of 1 gram daily for up to 2 months as a maintenance dose, reduces the incidence of acute episodes by 71%. So that means 7 out of 10 of your patients wouldn't get a relapse of their disease. Unfortunately, if there's a relapse, in the unfortunate case scenarios, the duration of the relapse and even the severity decreases significantly because you put your patients on the maintenance dose of Daflon. And this was seen in a long-term double-blind randomized placebo control study on 120 patients who suffered from acute hemorrhoidal attacks in the previous 2 months. Okay, so it goes on to say that the number of patients who had at least one acute episode was significantly lower in the MPFF group, which is Daflon, compared with the placebo group. So this is very important. You don't reduce the incidence of a relapse after treating the acute phase. Daflon is your best choice and your best option. Okay, and then even when it comes to pain management after surgery, Daflon has used in post-hemorrhoidectomy. Okay, so the incidence of analgesic consumption reduces significantly when you put your patients on Daflon after surgery. So to conclude, the dose of Daflon is very simple, just like para. In the acute phase, 1 gram TDS for 7 days. And then if you want to do a maintenance dose to reduce the incidence of a relapse, you can do 1 gram daily for up to 2 months as the maintenance dose. Thank you so much. So we are on standby for your questions for Dr. Nema to answer to them. Thank you. Okay, so this is from Barbara Botte. She's asking, so doc, would you have to add antibiotics to Daflon? Dr. Nema, so please, this is a question for you.
Yes.
Barbara Botte is
Right.
asking, would you have to add antibiotics to Daflon?
Right. Thank you very much, Barbara, for your question. Generally, for the treatment of hemorrhoids, we do not add antibiotics. The only time that antibiotics may be indicated is during complicated situations. That is, hemorrhoids that are being complicated. And what are the conditions, or what are the complicated ones? We have hemorrhoids that are strangulated, hemorrhoids that are, what do we call it? We call it fourth degree, highly edematous, hemorrhoids. And then those ones that are thrombosed for a long period of time. When it happens like that, then the chances of you developing, perianal abscesses as a result of these complications are high. Therefore, putting your patient, under antibiotic coverage whilst they take, Daflon under these conditions is quite necessary. So it's only for complicated cases, but the general ones, no, we do not add antibiotics to Daflon. Thank you. Yes, we have a
Thank you so
question from.
much for.
Yeah, we have a question from Fred Ansan in Kumasi. He said, "How does alcohol cause hemorrhoids?" Yeah, we made mention of the risk factors of alcohol, of risk factors for developing hemorrhoids, and we said alcohol is one of them. In fact, alcohol causes a lot of things in the human body. Starting from derangement of water, which can cause you to have chronic constipation, and a whole lot of systemic diseases. Now, all these things actually can predispose you to straining, which could actually lead, to development of hemorrhoids. So actually, it is related to the straining, pathogenesis mechanism of hemorrhoids, and alcohol leading to, chronic liver diseases, leading to, pancreatic diseases, leading to, a whole lot of gastrointestinal disorders could actually predispose you to straining. And that is how alcohol is implicated in the development of hemorrhoids. Thank you. We have another question from Barbara Bote. You say, in the case of infected hemorrhoids, I don't know whether it is a question or it is a suggestion. I don't really get it, Barbara, but you were asking, you just put a statement that infected hemorrhoids, or I don't know whether you're asking whether we have something called infected hemorrhoids. Generally, hemorrhoids, we look at the nature, how I described them, they do not get infected. I mean, if they get infected, then the whole situation is going to turn into the condition we call perianal abscesses, that you are going to develop abscesses. So we cannot, we have complicated hemorrhoids which are, strangulated or which are thrombosed. Sometimes they can be ulcerated. And finally, if you do not take good care of them, then bacterial translocation into these, engorged venous, what they call it, concussions, could actually lead to infection, and that will turn into perianal abscesses, actually. Yes. So, yes, hemorrhoids can get infected, but when they get infected, then it turns into perianal abscess. Thank you. We have a question from Philip, and is Daflon safe in pregnancy? I think our pharmacist would jump in here. Yes, the evidence suggests that pregnant women could use Daflon. There's no very strong evidence to suggest that they cannot take Daflon. However, it is much more recommended that they take it after the first trimester. That makes it more safer. We still don't have any evidence to suggest that within the first trimester, indeed, it causes any, problem as far as the development of the fetus is concerned. But the evidence out there suggests that if indeed it has to be taken, then it is more preferable to be taken after the second semester. I don't know whether our pharmacist has anything to add as far as the use of Daflon in pregnancy is concerned.
Yes, so Dr. Nema, I think you've answered it right. So all the studies we've done on Daflon were done in pregnant women after first trimester. So for the moment, we would say that after first trimester, it might be safe to use, but then the benefit should outweigh the risk. Yes, for these patients. So as you rightly mentioned, after first trimester, yes, you can use Daflon.
I think we have a question from Alex Kwanzaa. He said, can Daflon be given to children, or how do you treat hemorrhoids in children? That's a very good question. I do not have much experience as far as pediatric cases are concerned. So I think our pharmacist will help out in here. I deal with adults most of the time. So in terms of children, I really don't know the use of Daflon with relating to pediatric cases. So if our pharmacist can help us with this.
Okay, sure. So with Daflon, the studies that we've done were not done in children. Okay, so the recommendation usually is that to be given to people above 12 years of age, because our assumption is that with being 12 years, you have the average weight that can accommodate the drug or can sustain the drug. So we've not done any studies in children, so we wouldn't say you can use Daflon to treat children. But usually if they are above the age of 12 years, yes, it could be safe for these people.
Right. Barbara is also coming back again. Barbara Bote is saying that, please, it was a continuation of my first question. Oh, okay. All right, Barbara. Okay, thank you very much. And I think I've answered it for you with relation to, infection with hemorrhoids. So thank you very much. Emmanuel Opoku is asking, can you add Hematenex to Daflon since the bleeding might have caused some anemia? Of course, certainly. Daflon does not treat the anemia associated with, with prolonged bleeding. If the person has bled as a result of, hemorrhoids, for which it's quite rare, we see a lot of patients coming to the emergency with severe anemia as a result of bleeding. Of course, certainly you treat the the anemia separately from the underlying cause, which is the hemorrhoids. So yes, you could give Daflon, and at the same time you could also give any other medication that you want to give to to treat the anemia associated with the bleeding. Yes, so hematinus can be used. We have Samuel Sifi is asking, are there significant side effects to the extensive use or overdose of Daflon? Talking about the side effects of Daflon. Yes, certainly every drug, every molecule out there is not 100%, I would say safe from side effects. There are some, some side effects with the use of, Daflon, for prolonged use of Daflon. Certainly, I will ask my pharmacist to come in here and give us some of the commonest side effects that we normally see with the use of the Daflon. Please.
Okay, Dr. Emma, thank you very much. So one of the commonest side effects is GI irritation, but that is very rare because Daflon is a natural compound from flavonoids. So a species of citrus. So you would note that it doesn't have the common side effects that's associated with some orthodox drugs, but occasionally some GI irritation. But we are severe. We are very particular about these responses from the patients, from the doctors. So whenever there is such instance, we make sure that we take a pharmacovigilance report, follow up with the FDA. If there's a need for us to update our leaflet to reflect these changes, we do that. So far, we've not had any feedback from anyone overdosing on Daflon for us to even know the significant side effect. But then generally, occasionally, GI irritation when it comes to the use of Daflon, but that's very rare. But if you find any such instance, always make sure that you report to any of the severe reps who come around so that we follow up extensively. Thank you.
I think the last thing I would like to add about that one is also what they call it, probably the possible incidence of what do you call it, of allergic reaction. Of course, it's a natural product, but sometimes some people might react to certain natural products. So there is also a possibility of a possible allergic reaction. So if something of that nature happens, then it's very necessary to report so that we can look into it. Thank you. We have Fariga asking, please explain further how standing for long hours causes hemorrhoids. Yes, thank you, Fariga. When I was explaining the pathophysiology underlining the cause of, or the development of hemorrhoids, I made mention of two, mechanisms. The first one we talked about straining, and then the second one we talk about the increase in the resting anal canal pressure. Standing long periods of time or sitting for long periods of time actually causes an increase in the resting anal canal pressure. And this is what is actually cause a reduction in the venous return, therefore making the venous, plexus within the hemorrhoid become engorged, and that actually disrupts the connective tissues around these venules, therefore causing the anal cushions to increase. So standing or sitting for longer periods causes increase in the resting anal canal, therefore leading to the development of hemorrhoids. So that's how long periods of standing can cause hemorrhoids. Thank you. Barbara Bote is asking again, what's the side effect of hemorrhoid? And I think our pharmacist has explained this quite explicitly. So, Barbara, if you were listening, I think that question has been answered. Enyonam is asking, is Daflon safe in children? I think that one has already been answered. He said, 12 years and above, it's quite safe to use hemorrhoids. What is the recommended dosage of hemorrhoids? He has also explained it during our presentation. We said in the acute phase, it's 1 gram 3 times daily, and in the maintenance phase, we can reduce it to 1 gram twice a day, or sometimes 1 gram once a day. I think we've answered all those ones. Yeah. Penyin is asking, the products literature for Daflon is acute phase. Acute phase is 6 tablets daily for some few days, then reduce it to 4 tablets, then 3 tablets. Please, why the dose reduction over 7 days? That's a good question. I think this one, our pharmacists have to come in. Why is it that there's a stepwise, dose reduction? We start in the acute phase. We start with 1 gram 3 times a day, and then later on you can reduce it to 1 gram twice a day, and so on and so forth. Thank you.
Okay, so Gideon, thanks for the question from docs and other people. So yes, the dose of down in our leaflet or the PI or the patient information leaflet is the 1 gram TDS for 4 days, and you taper down to 1 gram BD for 3 days. So this was the initial dosage through our studies that we did, but then realized that dosage was quite cumbersome for patients to hair and even for doctors to recall. So further studies were done to show that if you give 1 gram TDS for 7 days, it still has that same effect and that same efficacy as giving 1 gram TDS for 4 days and 1 gram BD for 3 days. So in a perspective, it's still the same dosage regimen, it's still the same effect. Reducing it so that maybe if you start for the first 4 days, the patient might have some relief, so you can taper it down. Okay, but it doesn't make any much difference between that previous dose and now. So to make things easier, is 1 gram TDS for 7 days, just like para. But then if you would want to be conservative and you go by the leaflet, you could still do your 1 gram TDS for 4 days and then 1 gram BD for 3 days. But as to how your patients would adhere, that's also another question. So we think that from the studies and to make things simple, 1 gram TDS for 7 days will be very optimal and ideal for everyone to adhere.
Rabote is asking, can Daflon be given to a breastfeeding mother and what are the contraindications? It's the same thing, I think, relation to the, what do we call it, to the pregnancy that we made mention. There's no strong evidence to suggest that, breastfeeding mothers cannot use Daflon. But like we said, we need to weigh the, what they call it, the advantages of using and not using it. If it can be, if the condition can be managed, or can be contained without the use of Daflon during breastfeeding, then it's much better. But if it is very acute, then certainly Daflon can be used in during breastfeeding. There's no evidence to suggest that breastfeeding mothers cannot or should not use Daflon. I don't know whether our pharmacists have any other information relating to this.
Exactly, Dr. Nyama. And well said. So Daflon doesn't appear appreciably in breast milk, so there's no evidence of it's contraindicated use in breastfeeding. So you could still use it, as you rightly said.
Yes, we have a JM asking, what is the modality of managing hemorrhoids in pregnancy? Can Daflon be used in pregnancy? I think we have extensively explained this. So, JM, if you are listening, then you have gotten the answers to your question. Amamo is asking, what is the role of anusol suppositories in the management of hemorrhoids? Anusols are actually, they are soothing, suppositories. What it does is that it causes some kind of analgesic effect around the, what they call it, around the anal canal when you insert them. Secondly, they do have some small effect of anti-inflammatory effect. That these swellings generally, because they are engorged, veins, sometimes they do begin to have some level of inflammation in it, for which anusol also have some kind of anti-inflammatory effect on them. So anusol, one, gives you a soothing effect, that is reducing the pain relating to the hemorrhoids, and then also secondly, it causes, what they call it, some kind of anti-inflammatory effect, therefore making the inflammation within the inner cushions to go a little bit down, and therefore helping to reduce the swelling. So that is the role of anusol in the treatment of hemorrhoids. Thank you, Golion. Barbara comes and asking, it is if it has GI irritation, can it be given to peptic ulcer disease patients with hemorrhoids? Oh, certainly, why not? I mean, these are two different entities altogether. The fact that the GI irritation doesn't necessarily mean that indeed it causes any mucosal ulceration or mucosal, what do you call it, scratches or inflammation. The irritation that the pharmacist was talking about basically, got to do with, some sort of, irritation that could lead to some kind of abdominal, probably maybe some level of abdominal discomfort, probably maybe some diarrhea as a result of increase in peristaltic movement as a result of irritation and so on, but does not actually cause ulceration. So peptic ulcer disease patients can't safely use hemorrhoids. Sorry, can't safely use Daflon, certainly. Kelson is asking, I currently have a patient with internal hemorrhoids from portal hypertension. Yes, that's one of the conditions that could also actually lead to development of hemorrhoids, which is bleeding profusely. I want to know if Daflon will help. Certainly, Daflon would help under this condition. So if you look at the pathophysiology or the mechanism of action of the Daflon, as we made mention of it, then certainly if you have portal hypertension patients who have varices, that's the we know it could be varices around the anal canal, and we know that these varices are actually what? They are veins. And we said that these, what do you call it, macronized, purified, what they call it, fractional flavonoids are actually what? Venotonics. That is, they help to what? To reduce the what they call it, the pressure within these veins. Then certainly, it is quite what they call it, useful when you have portal hypertension patients who are bleeding. Let me also say that in fact, Daflon initially, when it was actually discovered, was actually not discovered for the use of hemorrhoids. It was actually discovered for the use of patients who have what do we call it? Venous insufficiency problems, and people who have, varicose veins and so on. And then later on, it was extrapolated to be used, for hemorrhoids. So it's a known, what they call it, I would say, molecule that has been used for several years for people who have problems with their veins, particularly people who have varices and the venous insufficiencies and so on. So if you do have a patient like that, then certainly they will benefit from that flow. Thank you. Maxim is asking, Kwabia J is asking, can Daflon equally be used for varicose veins as virtually follows the same mechanism? Excellent. And that's exactly what I just answered. That, in fact, that was what actually originally one of the indications for the use of Daflon was for varicose veins. Thank you. And Kwabia J is asking again, can Daflon equally be used for, I think we've answered this question, so we can move on. Akudazi is asking, what is the dose of Daflon for the management of varicose veins? It's same dosage, 1 gram 3 times daily is enough to be used for a period of 1 week. You can even extend it to a period of about 2 weeks. So it can also be used for varicose veins. What is the cost effectiveness in comparison with topical products for external hemorrhoids? Now, this is a very good question. For external hemorrhoids, now, we made mention that external hemorrhoids are the hemorrhoids that are formed below the dentate line. Generally, external hemorrhoids do not bleed. That is one factor, because generally they are below the dentate line. So generally they would not bleed. External hemorrhoids become problematic mostly when it is thrombosed. And when it's thrombosed, it causes pain because it is supplied with what? With somatic nerves. So when I was doing the presentation, I said that because of their unique, innervation, external hemorrhoids are painful, whereas internal hemorrhoids are not painful unless they are complicated. So if you have external hemorrhoids, you will only have problem with it when you begin to have pain in it. All right. So yes, Daflon can be used in the case of external hemorrhoids because they are, what is actually causing the swelling is almost the same. But generally, these hemorrhoids will not bleed. So we don't expect any patient with external, hemorrhoids coming to the hospital with complaint of bleeding. They normally come to the hospital with complaint of what? Of pain. And mostly some of them are actually what? Thrombosed. So if you have external hemorrhoid that is thrombosed, yes, the pain is quite excruciating. You immediately start your patient on Daflon. And then also you have to go ahead and properly do a thrombectomy for this patient. That is, you need to release those the clots that are within these external hemorrhoidal package that is causing the pain, and they will have very good relief after this procedure, and you combine your Daflon to it, and then you get your patient treated. Thank you. We have Amma asking, please, is the product literature, in the product literature, it states that for hemorrhoids, the 6 tablets. I think this question has been answered. So, Amma, if you are listening, you may have gotten your answer earlier on. Thank you. Also, Dapa, what is the cost effective in comparison with topical product for external hemorrhoids? I think I have answered that question. We're talking about the use of anusols and so on. So, also, Dapa, if you are listening, you've gotten your answer to your question. Ejaya Murphy is asking how much that Daflon cost. That one, I will leave it for Xavier to answer that question for me. Right. they're asking for the cost of
Mm-hmm.
that phone, please.
That's like a cut across board. So it's 150 for a pack of 30 tablets.
Okay. We are also asking, can hesperidine alone manage the pain in hemorrhoidal patient as the hemorrhoidal patient goes through? Yes, you made mention that hesperidine is part of the what they call it of the macronized purified, flavonoid for which Daflon is a typical example, and it actually causes reduction in the pain. Yes, that is a component of the Daflon that actually helps in reducing the pain. Can it alone, what do you call it? You're asking whether hesperidine alone can reduce the pain. Yeah, that's the function of the hesperidine. And that's why it has only been combined with the diospin and the other products, or the other what do you call it? The other molecules that are part of Daflon. So yes, hesperidine does reduce the pain, that hemorrhoidal patients go through. Ampof is asking, is Daflon safe in sickle cell patients? Yes, there's no indication or there's no evidence to show that Daflon actually predisposes patients to sickle cell, crisis. So therefore, any patient who is any sickle cell patient is safe to use Daflon. Yes. Nate, Dr. Nate is asking, is Daflon safe in GSSPD patients? Yes, it's safe in GSSPD patients. There's no evidence to suggest that patients with GSSPD cannot take Daflon. So yes, they can take Daflon. Dr. Peggy, so I have a hemorrhoidal patient who has already been treated with Daflon for a week. She recently came back with same complaints. Please, what should I do? Good, Dr. Peggy, for asking this question. Yes, you treated your patient with Daflon, and the patient has come back. First, I would want you to actually, look at the what do you call it, the degree of the hemorrhoid. If the hemorrhoid falls within the advanced degree, that is, we're talking about grade 3 and above, certainly treating them with Daflon alone might not relieve them 100% from their symptoms, particularly if they come back with recurrence. So if you have grade 3 and above and you've already tried with hemorrhoid with Daflon and it's not working, then I may recommend that you combine the Daflon with an office procedure. I would also want you to look at the dosage of the Daflon that you are also using, quite critical. If you are not using the optimal dosage, you may not get the actual benefit. So look at the dosage, look at whether the patient is actually compliant with the medication, and also look at the grade of the hemorrhoids. Then you can make the decision forward. If it is grade 3 and above, refer the patient for an office procedure whilst you continue the Daflon. If the patient is not compliant with the medications, or the dosage is actually, or the patient is under dosage, then relook at it, give the right dosage, and I'm sure your patient will benefit. Thank you. All right.
Um, I don't think we have any more questions. So thank you so much to our facilitator, Dr. Nyama. Thank you so much for your time and then for your knowledge and for your expertise in managing patients with hemorrhoidal disease and for sharing your experience with us. I think it's been very, very insightful and very educative. And I'm sure we'll
Thank
add
you.
this knowledge to our practice. And thank you to everyone of us who was able to join and stay. Thanks for your patience and thanks for bearing with us. Although we had a technical challenge at the beginning of this presentation. Thank you so much. And I'm sure that we'll be able to treat our patients with hemorrhoidal disease better with enough information and with enough options. And I entreat all of you not to forget about Daflon when you have patients with hemorrhoidal disease. Remember that the dose of Daflon is just like para, 1 gram TDS for 7 days in the acute phase. And then you can do a maintenance dose of 1 gram daily up to 2 months. And this prevents the incidence of a relapse. And unfortunately, if there's a relapse, the severity and the mean duration of action of the relapse also decreases. Thank you so much for your time. And have a lovely evening, everyone. Bye.